My check. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And we are into the 30th chapter. Woo! Peace, YouTube. Love, 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 love. Pick up page 439. Defining ARDS. Right. Chapter 30 of Clinical Application of Respiratory Care. I'm your moderator and narrator, Uriel Riley. Welcome, YouTube. Here we go. Chapter 30, the Adult Respiratory Distress Syndrome, ARDS. Defining ARDS. History. An organ system's response to physiologic stress is limited to several cellular and or tissue reactions. For example, inflammation is a general type of tissue reaction to stress. Pulmonary inflammation may be caused by bacterial, viral, allergic, traumatic, or chemical stresses. Although there are variations in the inflammatory response, it remains a single type of tissue response to stresses of varying etiology. The lung may react to stress by becoming stiff, i.e., poorly compliant. This was first recognized as a common occurrence in World War II and was termed shock lung. For the following 25 years, this type of lung response to stress was referred to by etiology. Table 31 lists some of the names under which this stiff lung syndrome was reported in medical literature from 1940 to 1970. This phenomenon was first described as a syndrome in 1967, and the name Adult Respiratory Distress Syndrome, ARDS, suggested. The most distinguishing factor is this description was the suggestion that an acutely decreased functional residual capacity, or FRC, was present and common to all ARDS. The following 4 years saw numerous investigations and documentations of this new lung syndrome. In 1971, the definitive publication describing the classifying the ARDS appeared. Table 32 lists only some of the causes that have been described for the ARDS in the past 10 years. It appears that almost any severe physiologic stress may result in ARDS. Peace, YouTube. Highest heart love. Welcome. Welcome. Peace. Live from the light here in LA. We are starting the 30th chapter of Clinical Application of Respiratory Care. Here we go. Pathology. Page 439 at the bottom. The lungs are beefy in appearance and do not readily collapse when removed from the chest cavity. Microscopically, there are 3 typical findings. 1. Hyaline membranes covering all alveolar epithelium and unassociated with significant bronchial pneumonia. 2. Interstitial edema and fibrosis, thickening of the alveolar and intralobular septa, which occurs early and is most probably secondary to accumulation of interstitial fluid. This early exudative phase progresses to a proliferative phase in which fibroblastic proliferation occurs. This later occurring fibrotic process is believed to be the only irreversible portion of the ARDS. 3. Pneumocyte hyperplasia, seen on appropriately stained light microscopic preparations as well as with the electron microscope. The hyperplasia is primarily type 2 cell proliferation and swelling, although type 1 cells are abnormal. And here is table 31. Chronologic order of some names appearing in medical literature referring to ARDS. Peace, YouTube. So it shows right here. And then table 32 is right under it. So table 31, chronological order of some names appearing in medical literature referring to ARDS. Oxygen toxicity, oxygen pneumonitis, respirator lung syndrome, shock lung, wet lung, adult hyaline membrane disease, congestive atelectasis, hemorrhagic pulmonary edema, non-cardiac pulmonary edema, stiff lung syndrome, post-pump lung, post-traumatic pulmonary insufficiency, post-non-traumatic pulmonary insufficiency. And then table 32, causes of ARDS commonly found in recent medical literature. Aspiration, chemical-induced lung injury, disseminated intravascular coagulation, drug ingestion, fat or air emboli, interstitial viral pneumonitis, massive blood transfusion, near drowning, non-thoracic trauma, oxygen toxicity, pancreatitis, prolonged cardiopulmonary bypass, radiation-induced lung injury, sepsis, shock, thoracic trauma, urema. Mm, mm, mm. Electron microscopic findings in ARDS include 1. Interstitial edema. 2. Proliferation of type 1 and type 2 cells with evidence of both nuclear and cytoplasmic abnormalities. And 3. Abnormality of cytoplasmic organelles of endothelial cells. Peace. Hi, it's Heart Love. What's going on? Hi, it's Heart Love. Welcome. The mods are in the building. What's going on? Thank you for the likes and subs and a peaceful part of YouTube where we read books and learn from masters. And I'm Master Fitness Trainer Uriel Riley. Thank you so much for reading with us. We are now entered the 30th chapter of this reading. We are at page 441. Here we go. At the top. Clinical pathophysiology. The vast majority of pulmonary abnormalities leading to acute respiratory failure are acute restrictive diseases, i.e., an acute decrease in total lung capacity, vital capacity, and functional residual capacity. See Chapter 20. All available evidence appears to support the statement that the ARDS involves an acute decrease in FRC similar to the third type of acute restrictive disease outlined in Figure 21. ARDS appears to involve a greater decrease in FRC than vital capacity, leading to the interpretation that significant loss of residual volume must be involved. Measurement of FRC is critically ill patients is difficult at present and must still be considered an clinical research endeavor. However, application of mass spectrometry at the bedside promises to provide routine serial measurement of FRC in the future. The first clinical pathophysiologic hallmark of ARDS is the presence of refractory hypoxemia, a moderate to severe arterial hypoxemia that is poorly responsive to increased concentrations of inspired oxygen. Any hypoxemia that dramatically responds to oxygen therapy is probably not the result of ARDS. This is not too intimate that all refractory hypoxemia is ARDS. To the contrary, other causes of refractory hypoxemia must be ruled out, e.g., anatomic shunt, lobar or segmental atelectasis, consolidating pneumonia prior to diagnosing the the existence of ARDS. The second clinical pathophysiologic hallmark of ARDS is dramatically decreased lung compliance. That's the key. In a spontaneously breathing patient, this is manifested as a significant increase in the work of breathing required to accomplish a normal minute ventilation. In a patient receiving IPPV, the presence of high inflation pressures or decrease of effective static compliance is noted. Although increased dead space ventilation is present, the most clinically significant physiologic abnormalities in ARDS are refractory hypoxemia and decreased lung compliance. That lung compliance is very key, right? Right down the yeah, this all right, so this chapter 30, is going to go into clinical studies and they have case studies here. So we're gonna stop before there and pause right before there, but um yeah, it's not gonna be one read. Love to the Dodgers. We did it. Yes, yes, love, peace, and love all around the world. Love to all our friends and family. Love to Toronto and Canada as well. Hi, it's hard love. Radiologic findings. The chest x ray typically reveals diffuse alveolar infiltrates in honeycomb patterns similar to that seen in alveolar proteinosis. The X ray findings are often quite typical, but unfortunately lag behind the pathophysiologic process by approximately 24 hours. In addition, a significant percentage of patients will not show classic patterns, but rather mimic the picture of cardiogenic pulmonary edema or a diffuse pneumonotic process. Often viral and other interstitial pneumonias will look similar to ours. Thus, the chest x ray should be considered confirmatory evidence for the diagnosis of ARDS, but cannot be counted upon as an independent diagnostic tool. Clinical presentation. In the spontaneously breathing patient without obvious acute cardiopulmonary disease, e.g., heart failure, pneumonia, atelectasis, respiratory distress that appears disproportionate to the blood gas and radiologic abnormalities is the most common early presentation of ARDS. Ding! The most common. You have to put a pin there. That's about bringing things together, the information that you have to make decisions, right? Rationale. See, that's why we read these books, because you're not just a professional just because you've practiced. You know what is the results of good care as opposed to bad care, solutions as opposed to speculations. It must be remembered that ARDS has a smaller infringement on vital capacity than most other acute restrictive pulmonary diseases, and therefore ventilatory reserves remain surprisingly intact. Thus, patients maintain a reasonably stable clinical status in spite of the increased work of breathing for a significant period of time. In addition, these patients most often have normal or below normal arterial PCO2s in response to the hypoxemia and seldom manifest cyanosis prior to cardiopulmonary collapse. In other words, the presence of cyanosis is extremely late and in extremis event for ARDS. In the patient being closely monitored in intensive care, ARDS most commonly presents as decreasing arterial PO2s that are poorly responsive to increases in inspired oxygen concentration, despite a clinical absence of obvious cardiopulmonary malfunction. Thank you for the likes and subs. We're pushing towards 600 on this friendly, peaceful channel where we read books and learn from masters. So, as you'll see, I will put in the description the actual vocabulary. And, you can do more research from there. That's what this is for, to give you this thousands of dollars worth of information out for free, and that's giving it to the people because we want the best for the people. Highest heart love. Shukran. Mia mia. Bonjour. Bonjour. Clinical diagnosis. The clinical diagnosis of ARDS is often difficult, especially in a patient with pre-existing cardiopulmonary disease. The clinician must consider ARDS a response of the lung to significant physiologic stress, and therefore, any patient who has been subjected to significant physiologic stress is a potential candidate. The syndrome occurs in all degrees of severity from very mild to overwhelming. Lesser degrees of ARDS may be a clinical significance in patients with limited cardiopulmonary hepatorenal, hepatorenal or CNS reserves. Symptomology and threat to life are as much related to cardiopulmonary reserves as to pathologic severity. The clinical index of suspicion for ARDS must be higher in patients with limited reserves. Making an early diagnosis is important because the process is totally reversible in almost all patients. in whom appropriate therapy is applied in early in the disease. Wow. The earlier the better. We learn this with all of anything with the CNS, right? How I've been able to turn back on the CNS in people that had strokes, which I'm currently doing with a patient as well. And it takes time. The longer that they have had that stroke is the longer it will also take to turn back on their CNS. So thank you so much for being here and reading with us. Highest heart, love, and honor. There we go. Making an early diagnosis is important because the process is totally reversible in almost all patients to whom appropriate therapy is applied early in the disease. All patients who have undergone significant physiologic stress and then manifest refractory hypoxemia in conjunction with an increased work of breathing must be evaluated for ARDS. Infant respiratory distress syndrome. Top of page 443. Infant respiratory distress syndrome. Much activity in the field of neonatology was devoted to the problem of infant respiratory distress syndrome, IRDS, IRDS, in the 1950s and 1960s. This disease, known as hyaline membrane disease of the newborn, was responsible for very high mortality, 80%, in premature babies. Pathologically and clinically, there is little difference between the respiratory distress syndrome of the infant and the adult. In fact, the name adult respiratory distress syndrome was coined because of its profound similarity to the infant respiratory distress syndrome. The cause of ERDS is most likely immature alveolar type 2 cells rather than stress alveolar type 2 cells. In spite of similarities, the respiratory care practitioner must not consider the discussion of ARDS in this text as generally applicable to the neonate. This is good, right? Thank you so much for reading with us. Yeah, I will put the vocabulary in the description when it's complete and you can go back in. I hope all of you took the time to go do your ancestral duty, as I like to call it, and vote today for all the elections that were held around. If you have the ability to do it again, you have the ability, activate, right? Especially your political power is powerful, right? Or else they wouldn't want to keep it from you. So hope you activate it. I did. Definitely. No doubt. I like to keep those. ARDS, a metabolic malfunction of lung. The adult respiratory distress syndrome, ARDS, is confusing subject in the medical literature, although much of this confusion is due to the short time span that the syndrome has been studied. About 15 years, we believe a significant degree of confusion is secondary to the failure to consider the syndrome as an intrinsic metabolic malfunction of lung parenchyma. Prior to 1950, little attention was paid to the existence of intrinsic pulmonary metabolism. The electron microscope has revealed the lung to be a significant metabolic organ. Perhaps the greatest challenge to pulmonary clinicians at present is to apply this recent realization of metabolic lung function to clinical practice. Without question, it is no longer acceptable to consider the lung a passive organ. Parenchymal metabolic function, epithelial function. Type 1 alveolar epithelial cells provide 95% of the surface area for gas exchange. Welcome to the peaceful part of YouTube where we read books and learn from masters and get this masterful material. That first sentence, that's definitely a highlight. Epithelial function. Type 1 alveolar epithelial cells provide 95% of the surface area for gas exchange. But the type 2 cell is the most numerous. The cytoplasmic junctions between alveolar type 1 cells are either touching or overlapping, i.e., there are no micropores, as exists with endothelial cells. Thus, the epithelium normally provides a watertight surface. The same appears to be true for the cytoplasmic junctions between alveolar type 1 and alveolar type 2 cells. However, there remains some controversy concerning this matter. The type 1 cells appear to be oxygen sensitive in that hypoxia results in cytoplasmic changes that affect cellular junctions and allow interstitial fluid to enter the air spaces. The normal fluid layer covering the epithelium is produced in type 2 cells and is secreted via microvilli that extend onto the alveolar surface. This fluid differs from plasma in both electrolyte and protein content. Production and secretions of surfactant also take places within the alveolar type 2 cells. See chapter 1. It is logical to assume that malfunction of these cells would lead to two phenomena. One, an aberrance from the normal content of alveolar fluid lining, and two, a change in either the quantity or quality of pulmonary surfactant. The mechanisms responsible for removing the fluid layer from the alveolar surface are not known. One suggestion is that the fluid flows toward the terminal bronchioles and becomes part of the mucus blanket as a result of normal expansion and contraction of the alveoli. Although this is an attractive theory, there are no supportive data to at present. Yeah, now we do. Another theory is that the macrophages remove all of the part of the fluid. Again, an attractive theory with little documentation. It can be safely stated that the fluid lining and its contents are constantly produced and removed from the alveolar surface. The mechanisms responsible for removal are unknown at present. And now we know this that diaphragmatic breath. The vibration, and the microcilia all together in a harmonic flow. I love history. Oh, I love it. I love it. I love it. Like all metabolically active cells, the alveolar type 2 cells appear to be easily damaged when severely physiologically stressed. A basic physiologic protective mechanism for prevention of such malfunction is the provision of increased blood and oxygen supply during blood periods of physiologic stress. In other words, a general body response to stress is to increase the nutrient supply to meet the increased metabolic demand placed on cells and tissues. The alveolar type 2 cells appear extraordinarily vulnerable since they are not supplied by systemic arterial blood. See chapter 1. It must be assumed that oxygenation of alveolar epithelial cells occurs by diffusion of alveolar oxygen or from interstitial fluid when alveolar oxygen is present. In addition, type 2 cell hyperoxia would result from alveolar hyperoxia and not from systemic arterial hyperoxemia. The profound metabolic activity of type 2 cells is unquestioned. Although specific function and mechanisms are largely unknown, a generally accepted pathologic observation is that when Ty- type 2 cells are abnormal, aberrant interstitial and endothelial cell function is almost always present. By contrast, pulmonary endothelial cell malfunction commonly occurs independent of type 2 cell abnormality. This raises the question: does the type 2 cell have functions that are essential to the proper functioning of pulmonary endothelial cells? Some indirect evidence has been found that the pulmonary sodium ion concentration may be monitored and altered by type 2 cell mechanisms. At present, it appears reasonable to ask, are normal alveolar type 2 cell functions required for normal interstitial and endothelial function? Future research will produce definitive answers. We'll pause right here. The top of page 455, just completing page 444. Live from the light. Thank you so much for the likes and subs. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're in the 30th chapter. Wow. We are the champions. Book reading on YouTube. Thank you so much. I will put the vocabulary in the description and of this episode 73. So when we reconvene, will be 74. Thank you so much for being here. Highest heart, love, and honor. Master Fitness Trainer, Uriel, Riley, as your narrator, moderator. We almost finished another book, so we're going to start pondering what's the next read, all right? If you want to send me an email or leave a message on one of the readings, next book is going to be coming up soon. We made it to November. Yeah. I want to give a big shout out to the Los Angeles Dodgers, champions of MLB baseball, back to back champions. We were doing it this time last year, like, yes. Oh, hi, it's Heart Love. All our friends and family, right? Live from the light, shaking it up on YouTube, reading books, high level books, super high level, shaking it up, right? Doing something they never seen before. Read something you've never read before, right? Hey, 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 shaking it up. Peace, peace. Love you so much. I had a beautiful outing. Remember when you take your walk, look up, see what you see. Long range, that blue, right? Long vision, indigo. See things coming. Long range. And you do that easy each time by following pattern recognition. I wish you divine awareness and love. Thank you so much for reading books with us. Highest heart, love, and honor. Peace, peace. Much love. Barely, what's going on? All right. Let's have a glass of love water. Right? Start a new chapter, chapter 30. So thankful and grateful for all that I have now and all that is coming to me. This has been an amazing, amazing, magical week. We have the grocery giveaway tomorrow and beautiful meditation with the great Lorianne Speed. I want to say thank you and love you. I love you to all my friends and family. Thank you so much. Great. All the goats. Look at you. Shine. We hold you up. We stand on your shoulders. Love you. Oh, I love you. I love you. I love you. That's so great. Yes. This is the part, right? Where I sing I love you. I do. I love you. I love you. You know it. Because I love myself. So grateful, thankful for all I have now and all that is coming. Praying for all our friends and family to the north, east, south, and west. I love you. Peace, peace. See you soon.